Good afternoon, everyone. My name is Evelyn Gallego. I'm the CEO and founder at EMI Advisors. We are a small advisory services firm located out of the Washington, D.C. area, primarily focused on supporting federal and state agencies in their digital transformation and policy and program alignment efforts. I'm delighted to be here today. Sure. Well, first, I meant to say earlier, thank you, Amar, and the partners for advancing health equity for the opportunity to speak to you today about organizational change and power sharing for health equity. So, as I mentioned, I'm the founder of EMI Advisors, and we work primarily with federal and state agencies. So, today I will draw on my experience supporting federal organizational change initiatives to address your questions. So I'd like to start by acknowledging that health equity cannot be achieved through isolated interventions. It does require, in my opinion, systems level change that addresses feedback loops between institutions, policies, and people with lived experience. So one example is my work with the U.S. Assistant Secretary for Technology and Policy, otherwise known as ASTP, also previously known as the Office of the National Coordinator, where we have been embedding health equity in their health information exchange initiatives for some time. So as you may already know, ASTP, previously ONC, was established as a federal agency following the passage of the 2009 HITECH Act, or Health Information Technology for Economic and Clinical Health Act. I acknowledge there's many acronyms, so I do want to clarify them first. So ASTP was charged with supporting the adoption of health IT nationwide and promoting standards-based health information exchange. So from the start, AST programs were highly clinically focused. They targeted health systems and clinicians, as well as the technologies or platforms these health systems use to collect, document, and exchange patient information. Fast forward 2014, ASTP initiated a joint project with CMS, the Centers for Medicare and Medicaid Services, to develop data standards for collecting and sharing person-centered plans required under the Medicaid Long-Term Services and Supports Programs, or LTSS programs. These plans include an individual's preferences and assess needs, which extend beyond clinical needs, right? And these assessed needs include what we now refer to as social drivers of health, or health-related social needs that do not tie into clinical care. At the time, the ASTP team that I was working with was not as familiar with defining social or non-clinical data elements. We started this work with CMS with a clinical lens, and we tried to define it in terms of the person's health concerns. Again, very clinically focused, and their problems, their problem list, without understanding what they needed to support their overall, or what we called then and soon learned as whole person care. So we had to sincerely pivot, I say, the way we approach the development of data standards. So before that, it was very healthcare centric, and we said, we really need to look at it from, at the time, again, health equity lens. Of course, health equity, or social determinants of health, social drivers of health, or SDOH, many names, they weren't buzzwords in 2014. We really started referring to them as person-centered, right? Not patient-centered. There was a lot of work at that time from quality improvement as patient at the center of care, but we started to shift it as the person, because 99% of our lives are spent as people, as a person, while 1% could be as a patient. So I say this thinking helped establish that cultural shift in the work that ASTP did, as well as my own work as a consultant. So I really see that as a growth, area, because we didn't think of these things in that way. So all of a sudden, all our projects that we engaged in began to examine data exchange and data interoperability within the context of how it supported the whole person, right? And whole person care. So beyond the healthcare system, where public health also played a role, community-based care, human services. Again, always thinking through of how does the care and the data we exchange reflect the person, the patient, and their lived experience. But based on your question too, how we did this was really, not anything astronomical, but really it was just bringing all the stakeholders to the table. It was as simple as that, is including community-based organizations, including the patient, the person, and their caregiver. Often caregivers being non-paid supports, right? And others with lived experience that could speak to how to define those data elements. So this learning, then we pivot again to 2019, fast forward to 2019, when I co-founded the Gravity Project with the Social Interventions Research and Evaluation Network, SIREN, with funding from the Robert Wood Johnson Foundation. And for those not familiar with the Gravity Project, it is the leading national public collaborative that develops national standards to collect and exchange social drivers of health, or SDOH data. I say that we wouldn't have had so much success with the Gravity work if we hadn't had that pivot or that cultural shift or organizational change that we learned through our ELTSS work, our electronic long-term services and support. I really say that because it helps sort of pave that way, that when we all of a sudden did stop calling it social determinants of health, that the federal partners that were initially very clinically focused, like ASTP and CMS, as well as the the Standards Development Organization, HL7, there was something to ground them, right? And they had already thought through about how could they extend and expand their data standards work. So, and I would say that Gravity's success as a very large collaborative right now is really rooted on how it aligns its change efforts within the ecosystem with the community voice, while working within the constraints of the health and social services ecosystems. Again, it's bringing everyone to the table, and we can talk about it a bit more. So I say now that mindset was in place to understand, with the ELTSS work and then Gravity, is really how we could create better language and data standards to collect and share this type of information that impacts all aspects of an individual's life. That includes, again, building on the health equity definition, includes their barriers, constraints, and circumstances, right? So really thinking at, what is it that they need? And I also say too that although health equity and related terms are currently not the ones we're supposed to use in our current environment, we see the work of Gravity and what states are doing. A lot of it is that they continue moving forward. So the work is still important. The grounding just helps set it, and we just move forward from that. So a lot of our work within EMI, we say change cannot happen without understanding the current systems in place that promote or constrain change and innovation. Because a lot of our work is around digital transformation, where innovation plays a key role. So, and this is why one of our core competencies at EMI is human-centered systems thinking, both of them together, where we solve problems and co-design solutions with our clients by understanding what current structural systems exist and what is the lived experience of people interacting with these systems. So I mentioned Gravity. My experience with Gravity has helped me understand that to better solve the care coordination problem between health systems and public health and social services or human services sectors, and at the same time promote health equity, we need to better understand the connections and interactions between the people in the systems. And we know there's several frameworks that exist. Again, this is near and dear to my heart of understanding what's a way to define this, and look at it within a health equity context. But we see that they all look at, they define health equity at a systems level, right? So think of it, overarching circle. And then when we think of social determinants or social drivers, they're defined within a community level that's embedded within that larger circle. And then nested within that community level is the social needs that reflect an individual at the individual level, right? So again, but you start with individual level, community, and then systems, right? So to achieve health equity at a systems level, we need to better address ongoing societal efforts that produce poor health while overall promoting well-being. So these two factors, and I say they're not mutually inclusive, right? They can happen at the same time. So in this way, we do see health equity as a complex adaptive system. So, it's continuously evolving, especially when we think of social drivers, right, that impact health equity. They're dynamic, right? They're not static. They're things that evolve depending on, again, the individual circumstances, constraints, and barriers, right? We bring that always back. So we say that, health equity is part of this complex adaptive system that incorporates clinical, social, environmental, political, and economic drivers of health. So all these things impact our overall well-being. Although we may focus very much on the clinical, the ones that cost our ecosystem more money, but knowing that all of these come into play. So once we understand what we can do at an overarching system level, we can, what I say, create better policies, practices, and norms to share how we address and respond to these social inequities. I will also say that equity-inspired change requires this rewiring of default processes. You probably hear this all the time. You've got change, it's around change management. So we want to rewire it. Again, with my lens, I'm always going to come from a data lens, right? So we have to do this beyond how we collect and use data, but also how we design policy, how we procure services, and how we hire, train, and promote people. So all of these have to come into play. So it's not, again, I'm coming with a data lens, but I know all these things have an impact. And that's why we also say change is a multi-level activity, but requires shared accountability around all actors involved. I love this question. I did love um, I always say too, with equity and what we've learned in the last several years, it does need to move beyond a buzzword. 'Cause, people it really needs to be part of an organization's values and culture, and thereby embedded in its governance and the incentives it has as an organization and accountability structures, right? No, and regardless of what we name it, right? So I will say from an EMI, although I'm speaking of our experience at EMI with federal agencies, my personal experience with them, equity is part of our values at EMI. So I think it's something that, regardless of what we call it, but being able to embed it. And I say it's sustainable when we shift not only the structures, but the feedback loops. So a lot of systems thinking is grounded on feedback loops, being able to create this, learning system, right? But you need to have feedback on how people receive information, how trust is built, and how decisions adapt over time. And unless you have this coming back, you're not able to learn and grow from it. I will say it's hindered when it is treated as a one-off initiative or priority, right? It's top-down leadership priority. It's only done, it's not being followed because it's not something that the people in the organization see themselves in. I also say that it's hindered when we medicalize health equity. where health systems impose their practices and their processes without community co-design and engagement. Another term I came across recently that really struck me around this notion, especially as we think of applying systems thinking to public health, is health imperialism. So I don't know if you've heard that word, where health is viewed as the primary interest of all involved, right? And so I think that is when we think of health equity or an equity, if you just focus it from something that, a top down and not really thinking of building and bringing everyone together, regardless of where they're at, then, it ends up being a top down and it's not adopted and thereby does not lead to change. Thanks, Omar. So I preface by saying power isn't always positional. It is embedded in data governance, budget decisions, and the prioritization of partnerships. Change and action, as we've seen a lot of our work, and we always say this even with our terms around health information exchange, it happens at the local level. As I mentioned earlier, I see health systems, health plans, state governments, and communities that they're moving forward with their health equity initiatives, even if they call them a different name. But to lead, to this change, we must map, and again, bringing the systems thinking lens, we must map where formal authority exists and where informal authority can thrive. So I love those words because I think that they go hand in hand. You can't just say, we're going to have a grassroots effort and everything. We've seen there's been success of grassroots effort, but there still needs to be a way to look at it from understanding what that formal authority is, what positions, where does power exist now, and what are those levers we need to be able to shift and have organizational change. So I really say that it happens at the intersection of both. Yeah, so it's really important, like all change efforts, to have a champion, right? So you have to have some level of executive or sponsored champion. This is crucial, and we see this all the time. And with that comes some buy-in at the top, right? It doesn't mean that the top has to lead it, but they have to buy in to allow the organization as a whole to move forward, right? And again, thinking through academic wise and Cotter's 8-step change model, if we reflect on it, we know that leaders may iterate change or initiate change. Step one, create urgency, as I look at it. But for them to actually shift and create change, they need to build coalitions, right? They need to empower their teams, and they need to embed this change in the culture, right? So without this, again, it becomes a top-down initiative. Um, Reflecting on my experience with Gravity, we were able to shift mindsets. Again, at the time, it was when we were creating standards, although we had this baseline we had done, as I mentioned, around ELTSS, it was still a significant shift to bring these very siloed ecosystems together around having SDOH or social drivers of health data interoperability. And, then this is, again, 2019, we kicked it off. It was something that was important for Siren as part of their mission around gathering evidence around social care integration. But at the time, we wouldn't have been able to do it if we hadn't brought and identified key champions across all the primary stakeholder groups. So when I talk about primary stakeholder Gravity, it included not only government, like federal and state agencies, we had champions from health systems, large integrated health systems, public and private. We had health plans, payers played a key role. We had community-based organizations or representatives from CBOs, right? Some of them never intersected with the health system, but they were brought because they understood their role in transitions of care and social referrals. And most importantly, we had people with lived experience and advocates for them, right? So they were there from the start. And I would say these champions help create the sense of urgency. And therefore, they help create and stand this public collaborative. So I failed to mention earlier, Gravity is actually 3,000 member plus. It's free to join. At the leadership level, they've shifted their model now, but from a governance. But initially, anyone can join to help co-design the standards and test them. And what we say is at the time to get this buy-in and have our champions really help proliferate the message we needed and the engagement. We said, we weren't building just data standards. We said, this is an opportunity for us to rewire a network and create these connecting nodes between systems that were functioning in silo. And it wasn't, also the success of it wasn't that we didn't stand up Gravity as a one-time convening, workshop, listening. It was really a collaborative, which has now evolved to a learning health system, right? So there's, lots of success. And the standards themselves continue to be shaped, right, by ongoing iteration. They develop new terminologies, they develop new data exchange standards, they test, and they have these feedback loops. So again, it's an example of how we're bringing this all together. Yeah, no, I want to emphasize, as we had this in mind. I forgot to say, researchers were also part of the Gravity project, but we didn't put them as primary ones to champion because they were, sort of that ground where they came in, and I would say the communities were there from the beginning, right? Because we didn't want them to be passive beneficiaries. The researchers came in after and Siren is a research institute, right? Gathers evidence. So they were there. They were, we co-founded, they were the co-founder of Gravity. So they were there from the beginning. And why they were there. So I do want to acknowledge Siren's role is because they wanted to shape how the data was collected, right? They wanted to do that from the start. They didn't want to retrofit, right? So Siren, as part of their work, gathers evidence, but they, have to go back and say, how do we integrate this? How do we better define and map? So they continue and do play a critical role. I will also just add from the private sector, right? So we had them involved in Gravity and they continue to be involved. And why they're important is because they help scale the work. Right. So it's not only just a one collaborative national, it's a public collaborative, public-private partnership. But you really need the private sector to drive it. And, if you do see a Gravity presentation, I have a visual where I show all the success factors of the project. And one of them is the ability of the private sector to innovate around the standards, right? To create new solutions, new technologies, new tools, to have a better way to collect and share this information to improve whole person health. So again, I really see the private sector at the end. You can have the policy, the program, the quality measures, the research, but you need the private sector to scale. And happy to share that visual too. It's helpful afterwards. So over why we started Gravity, because there was a economic interest from the private sector to collect all data about a person. And this was very much tied to the shift at the time to value-based payment models. And, this is why it was an interest in particular to the health plans. They wanted to be able to track as a patient, a member, went through, received services and care, and they wanted to be, the closed loop referrals were. So I would say there's always been that economic, and from the health system as well, they wanted to reduce readmissions, right? They wanted to be able to easily locate other supports in the community to serve the patient, so it wasn't an evolving door, right? um, we also, at the time when we kicked it off, and we continue to do now, there's evolve, it's so much more. Again, thank you to Siren. I will call them out because this is their role. They gather this evidence, right? That really demonstrates that addressing an individual's social needs and community social determinants of health can improve health outcomes, right? And reduce healthcare costs, right? So we have examples of how having this information and embedding equity in overall care delivery helps reduce costs associated with readmissions, hospitalization, and nursing home stays, right? So the evidence is there. Shout out to the Commonwealth Fund and Health Begins. Again, I think also some funding from RWJF, but the Commonwealth Fund has a return on investment calculator for partnerships to address social needs. So lots of evidence there, and they continue to add to it. I will also say that for businesses, so we think overall, big picture, inclusive practices we know that enhance talent retention and brand reputation. People want to work for organizations that embed equity in their values, and what I say, and practice what they preach. And people want to buy from or obtain services from organizations that respect that and value that. So case in point, think of the public reaction to companies that recently did not roll back their DEI initiatives under the new administration, right? So there's lots of evidence there about all of a sudden people, banning one organization, they shall remain nameless right now, and going to purchase from somewhere else because they continued with their equity-driven practices. So I think this is important overall, and we continue to see it again, regardless of what you call it. But these are things that there are business economic incentives in place for organizations to take a look at this and what I say, practice what they preach, right? Because they're going to be able to retain the talent that they need to continue to evolve and grow. Yes, no, I love this. I love the questions that were posed, and it gave me an example to reflect on my own experience and how we can continue to disseminate this information, but also promote. That's what I meant to say. Promote. The other word I had was mobilize, right? How can we further mobilize the shift and create the organizational change we need? Because I do see, again, it happens at the local level, and we want to be able to share more success that is happening in the field. Thank you, Omar.
Thank you so much. I think that's a wrap.